now.
Good afternoon, good evening, good morning, wherever you are in the world, and welcome to the panel discussion following the excellent lecture we've had earlier on from Dr. Pate. It's my pleasure to introduce the panel, and we would have about an hour of discussion. Initially, we'd have questions to the panel members, and for the second half, we would have Q&A taken from the audience. So I will start by initially introducing our panel members. It's a pleasure to have you, Dr. Mohammed Ali Pate, Director of Global Health at the World Bank and Director of the Global Financing Facility. We also have Professor Ann Blandford, who is the Deputy Director of the UCL Institute of Healthcare Engineering, and Professor Andrew Hayward, the Director of the Institute of Epidemiology and Healthcare at UCL. A pleasure to have you all. So I'd like to kick off by asking the panel, starting with Dr. Pate, to reflect on, given the disruption that COVID has caused across all of society, what opportunities do they see, both for the health system, but also for wider society going forward, the research necessary, and what actions can be taken? Dr. Pate?
Thank you. I think obviously we are going through a profound shock, and the ultimate, where it lands is far from being clear, but it's likely going to be more severe than we had all imagined a few months ago. So this is not a surprise in a way. We had known all along that this was a possibility, but the level of preparedness, I would say, has been suboptimal. Prior to this pandemic, the average core capacities in terms of assessment of those core capacities at the national level, for instance, in some regions, is just about half what it should be. And even with those capacities in countries, we've seen countries struggle to cope with it. So it also, I think, offers, let's say, the motivation now for policymakers, for political leaders to think about investing in health and in health security, not only from the point of view of just preventing morbidity and mortality, but from their own economic security and even national security. So if there's any question in the minds of finance ministers or planning ministers or health ministers or heads of state as to why investing in health and financing health adequately, building strong national institutions, really relying on good science to guide public policies regarding health, but also more broadly in terms of protecting society, COVID-19 pandemic has really provided the ultimate in terms of motivation for that. Just building back on what Ann also earlier in her remarks alluded to. So I think that's the upside of this very traumatic experience that we are still going through.
Excellent. Thank you very much. Can I ask Ann to reflect from a technology perspective, the same question about what does this mean for us and where are we going?
Well, very clearly, we have learned a lot in the past few months about how valuable technology can be. As I said in my response, we have learned a lot about COVID-19 much more rapidly than was possible for earlier pandemics because of the availability of data and the ease of communication. So that I think there have been some very positive aspects to it. I think we've also highlighted needs, as well as needs for PPE and for physical infrastructure, needs for high quality digital infrastructure, for secure data repositories that will allow us to learn more quickly. When we think back to December or January, we knew so little about this, and we were, people were winging it. trying to work out what the best possible answers were. And, you know, that's still the case to a significant degree, that we don't have all the answers yet. But hopefully with the technologies that we have available to us and development of algorithms, development of ways of sharing data in a secure way, we will actually learn more about this pandemic than we have about earlier ones. And that will put us hopefully in a stronger position. But it does rely on international cooperation and governments and world leaders working together in ways that seem to have been quite challenging in the last few months.
Thank you very much for that, Anne. So coming closer to home, Andrew, I wonder whether you can reflect from a UK perspective. Where are we heading?
Well, I think your initial question also talks a bit about opportunities. So, I mean, I think it's important to both think about the challenges that we're facing, but also some of the opportunities that COVID has presented. And that sounds an odd thing to say, but I think some of the things that have happened are an ability to do things at local level and make decisions quicker and bring groups together faster than might have been possible in other circumstances. So this idea that it's usually very, very hard to shift things within the NHS, yet we've seen an ability to move from, you know, digital being a, you know, an idea that sounds like a good idea but nobody does, to something that's being operationalized at scale. So, you know, as a small example for that, in the areas that I work in, inclusion health, we've seen, for example, years and years of trying to get telemedicine into prison. Now it's universally available across the prison sector. So there's some opportunities. I suppose other opportunities that one might see in terms of, you know, everybody's working in a radically different way. And of course, that's having huge impacts on the economy, but it's also having a, you know, very positive impacts on the environment and green issues. I think the pandemic has really brought about a bit more of a shared sense of identity and our interdependence, and perhaps a bigger understanding of some of the social issues and the need for social protection to be improved across society. So there's a certain sort of solidarity that arises from this event, but I think it's all potentially very fragile as we move back to, if you like, more normal times, however quickly that may be and what we mean by normal. Some of these gains that could have been achieved could be lost fairly quickly.
Thank you very much for that, Andrew. So I can see very clearly a theme emerging from all three of you of greater multilateralism and greater cooperation and collaboration between countries, which is a goal most of us in global health would agree with. But the emergence of crude competition between countries, whether it's for vaccine, drug, or personal protective equipment, really challenges that. Do you have any reflections as to how we best tackle that going forward, given the political context in many, many countries around the world? Perhaps, again, I would like to start with Dr. Pate.
Thank you. I think what you stated is really reflecting the state of the world as we are today. And clearly, there's an opportunity to think differently going forward. And one way is to really, in a way, anchor responsibility around the composite members within the multilateral community, around nation states. So the national governments themselves are the key underpinning, and voices across the spectrum to be included in the dialogue, to forge really genuine consensus, but also recognizing that that interdependency is so vital to be acknowledged and to be reflected in perhaps even the wealthier sort of high-income countries in terms of supporting the most vulnerable parts of the global community. We are all in this together. I think if we come out of this experience with that appreciation and with national leaders recognizing that they have to do their own part within their own nation states, but also they have to really think outwardly as to how we all collaborate collectively would need to solve some important issues like pandemics, or it might be climate, or it may be some other issues, or in terms of inequality within and across countries. Then I think we'll have learned a very valuable lesson from this experience. So
the questions are streaming in, and I'd like to take one from Dr. Richard Horton, which is directed at you, Dr. Pate, and it builds on exactly that response. Richard says, I enjoy Dr. Pate's optimism about the importance of political will, but why should the post-COVID-19 age be any different from the past health emergencies where the lessons have not been learned?
Well, big question, and I think we'll still have to see. 3 years ago, all our expectation was the global pandemic will be largely in the south, among a few poor countries, costing about 1% of global GDP and is contained, really thinking from Ebola. COVID-19 has upturned that. Already we are 5%, more than 5%, and it's continuing to go deeper. And I think we have to be hopeful that the global leaders would learn the right lesson, but also citizens would actually see how that lack of preparedness and lack of investments in health security can undermine not only human health, but also livelihoods, and that political leaders be held accountable for their failures to deal with this crisis. Ultimately, I think that's the realm where this will be resolved. And the choices that people will be making over the period ahead in terms of how their leaders responded to this, I think will be sure whether the lesson has been learned. Failure to do that, we would have additional other emergent threats. Antimicrobial resistance is lurking just behind the corner, and we have to also deal with it. It has huge costs, not only in human life, but also in economic cost. So I think there's a reason to be optimistic given the severity of the lesson that is very different from what we had experienced, let's say even with Ebola, which was limited to a few countries in West Africa, or the others that have been geographically localized. This has cut across, and in fact, even the highest income countries have really taken a huge brunt from not only their own lack of preparedness, but also lack of global preparedness. So I'm hoping that we'll emerge from this learning the lesson. If we don't learn the lesson, I think we'll unfortunately go to what Richard alluded to, the panic and neglect cycle, which will be unfortunate.
Thank you very much for that, Mohammed. Richard has a question for you too, Andrew, and I'll go to that straight on. You focus especially on marginalized and vulnerable groups, an area you've been working on now for a decade or two. As an expert in inclusion health, what policies should we be putting in place to make sure that those who are so often excluded are no longer left behind? I think this is from the UK perspective.
Well, I think I'll talk from the UK perspective, but I think it's international. It's very easy to design control procedures that really don't take into account the most marginalized in society who are not going to fit into the normal advice and systems. So, you know, say in the UK, it was very obvious that, you know, if you're getting advice to self-isolate and stay at home, that clearly doesn't work if you don't have a home. And so sorting those, you know, I think in any public health strategy, you always have to think about how that public health strategy impacts on inequalities, and particularly how it's going to work with the most marginalized people. And so I think the most marginalized groups have really had a great deal of the brunt of this internationally, and not only of the disease, but also of the control measures. And I think it's really important that we recognize that a lot of the control measures that we're asking people to do are disproportionately affecting those people in the poorest parts of society. So, you know, asking people to self-isolate when they become ill or when they become a contact is relatively easy for people who are in a stable, full-time paid job, and that's not going to affect their income. But if you don't have that protection, then this really doesn't enable people to participate and potentially just drives people into a great deal more poverty. And so I think going forward, we really, this is going to be one of the major impacts of the pandemic is, you know, increasing unemployment, increasing poverty. And if we're not careful, that poverty will lead to increasing destitution as well. And all of that will be bad for disease control too.
Thank you very much for that, Andrew. So that issue, as you rightly pointed out, is pertinent for lower middle income countries where there's a larger proportion of poorer people, and many of the measures we've taken disproportionately affects those same people that are excluded from society. And I agree with your suggestions. So Anne, if I might move to you, with your expertise in computer-human interfaces and the human bits of technology and clarity that we need humans for any technology to be useful, i.e. humans to change their behavior, I'd be interested in your thoughts on the idea that many developing countries are being presented, essentially some national response teams are being hounded by people with their app as to the magic solution for the COVID problem. What advice would you have for individuals or countries that are considering an app to address COVID?
And firstly, an app has a role, but it cannot work on its own. It has to work in conjunction with other kinds of interventions, you know, from relatively low cost interventions like face masks and social distancing, through to much higher cost ones, particularly for people who fall ill. But I think there are issues around good design of apps, whether that is, I mean, I included the example of the King's College tracking app in my talk. You know, that is designed on the assumption that we're prepared to give up certain kinds of data about ourselves for the common good. There has to be that kind of trust for any track and trace app to work. The alternative is the kind of enforcement that we have seen in some countries that have been in some ways very successful, you know, where one's freedoms are limited if one doesn't use the app and doesn't kind of prove that one is as far as possible, you know, COVID free when traveling, for example. But different countries have different attitudes to kind of what's for the common good and the risks to individual privacy versus those rights to privacy and less interaction for the common good. And each country, because we have different value systems, not just as countries, but as kind of cultures and individuals even, we need to keep working on what is actually going to work technologically, both in terms of tracing apps and in terms of other kinds of data sharing and in providing information to people to help us all to understand what we're doing and why we're doing and how we keep ourselves and society safe.
Thanks.
But I guess another really positive thing is that you know, mobile technologies are not necessarily much more prevalent in low and middle income countries, but have much more dominance within those environments compared to laptops and tablets and kind of more expensive fixed bits of technology infrastructure. So you can do things with phones, particularly less smartphones, that perhaps you can't do with more sophisticated technology right now. Of course, it will change in a few years.
Thank you very much for that, Anne. So I'd like to move us now to the audience questions. But before I do so, I'd like to thank the many who have contributed questions. We have quite a few to go through. But if you do have questions, please feel free to type them in and they'll be published and I can pick from them. You can also upvote questions and I'll be selecting from questions that have the highest votes because those are the ones that many people want to hear about. So I'd like to kick off with the most controversial one, and I'd like my panel to be prepared for this one. Right. What are the potential implications of the US withdrawal from the WHO and other institutions? Would WHO function effectively without US involvement? From an anonymous person. I wonder, Andrew, whether you would like to start this one.
Well, it is fairly extraordinary, isn't it, that anybody would consider disinvesting in WHO at this time. I think it's extraordinarily negative. I'm sure the WHO can survive this, and the rest of the world will rally round WHO to support its essential function. And I hope in time that the United States will see that this is an entirely retrogressive and unhelpful action globally.
Thank you, Andrew, for that response. In the interest of having to reach as many questions as possible, I'm happy for panel members to respond to that question, but I will want to move us on to the next one, which is from Georgia Chisnell. It goes, I'm currently conducting a global investigation into the untapped potential of qualitative data in informing the epidemic response efforts in terms of data type, collection, dissemination, usability, and the determinants, i.e. enablers and barriers of qualitative data use. I welcome any comments and reflections on this topic in regard of the COVID-19 epidemic. Again, perhaps Andrew, you could start and then we could get a view from Dr. Pate as well.
I mean, I think that's an incredibly important scientific question, actually. I think I've sat on the main funding panels in the UK for some of the rapid response calls, and a very small proportion of the work that's coming through is of a qualitative nature. And I think that's a really huge gap in the scientific understanding. And if we really want to understand how these control measures are playing out, what we can expect people to do, then I think we need that much more qualitative aspects to the research to complement the quantitative side. And I think that's particularly valuable for understanding the pandemic from the perspective of different cultures within our society. Particularly, for example, trying to understand some of the BAME issues, why this disparity in mortality has occurred, and how we can respond to that needs to be done, both with a sort of qualitative understanding, but I think also I would move to also say that the sort of co-production type approaches to the solutions are really necessary. So, having conversations with people from communities as to, what their understandings of the disease are, what the levels of stigma, for example, are, what sort of control measures are going to work in their context.
Thank you very much, Andrew. Thank you for that response. Mohammed?
Yes, I think just this underlies the central point that the threat is multi-sectoral, and that our understanding of it require an approach that goes also in a multi-sectoral way, including the qualitative aspect, to understand really not only the behaviors, but also how people are perceiving or responding to the threat in their own lives and in their own communities. Within the context of COVID, but also other infectious disease threats, for instance, animal health and communities in terms of their understanding, I think it will be very important. And building those capacities is also a key part of it, because without that, then our understanding will be limited, and the effectiveness of our response really will be should change in that way. So I think it's an important element that we should pay attention to in terms of the lessons that we're learning from this pandemic. So the multi-sectoral nature, but also bringing in the qualitative aspect also in terms of the data that is collected, interpreting that, but also using that in helping address threats such as this. Back to your question, the earlier question on WHO, I hope we would learn over time, really including the role of key technical agencies in responding to threat like COVID. So I think that's an important, also another learning moment that countries will have to go through soul searching as to whether it makes sense actually to undermine institutions like WHO. At the moment, WHO is the key global health leader in a way that has sort of set the standards. And so I hope that as this unfolds over the next 1 year, with the learning from that there'll be a lot of soul searching and reflection within countries as to what it means not to have such an institution strengthened.
Thank you very much for that, Mohammed. So there is a related question from Ian Scott, who is the director of the UCL Grand Challenges. He wants to know that what you think about the impact of the COVID crisis in bringing together multilateral organizations like the World Bank and the WHO together, and in what ways does the World Bank's preparedness to deal with future epidemics change in response to this sort of linking up of multilateral organizations in relation to the apportioning of efforts for planning?
Yeah, so I think even before the West African Ebola outbreak in 2014, there were very close collaborative efforts with WHO, the bank, and other institutions on the global stage. I think 2014 was a watershed, and among the several panels that were assembled on the global stage, the bank and WHO continue to collaborate, including co-convening the GPMB. The GPMB made its first report. It's an independent board, but it's co-convened by WHO and the bank. So the bank's work on financing in a way was within a global architecture that had WHO playing a technical role that is important in that way. So as we move forward, I think we're the response, in fact, as the bank has unleashed this huge effort supporting more than 100 countries in the COVID pandemic response, which is unprecedented with financing, but it's framed within the strategic response plan, which WHO had developed. So that collaboration has continued, but it needed to move beyond the global to the country level where the implementation by national governments needs to happen. That's been our focus. And I think as we move forward, less of the global conversation, but more of the country focused discussions and actions that are needed will be very key for us to help the world collectively to be better prepared, not only to anticipate future threats, but also to respond to them when they occur. So that is one of the takeaways for us. Translating that global, let's say, the global agendas into country actions is one of those, and linking not only the preparedness and health security discussions, but to link it with the universal health coverage movement and strengthening country health systems will be very key as we emerge out of this pandemic.
Thank you, Mohammed. So Anne, I have a couple of questions for you, and I'll take them one at a time. I'll start with the first one. So as discussed, the pandemic has revealed the importance and potential of digital technology in pandemic preparedness and response. Yet its intensive use in information dissemination and connecting people has been constructed as a barrier for those unable to access these platforms. How can we overcome this?
That is such an important question. I was trying to think about the answer to it before we opened today. And it seems to me that part of the answer is that where we can make the technology use kind of simple, and I'm not using that in patronizing sense at all, but in, can use lower levels of technology, non-smart kinds of phones, for example, that increases accessibility for a broader sector of society internationally. We're also finding that people are seeking help, certainly in this country, which is the place where I have highest visibility of it. We're finding that Digital.now and other initiatives that are trying to make technology available to people who don't yet have access to it, whether that's elderly people, school children who haven't had access to technology to be able to do the schoolwork that's been sent home during this time, various other groups who have needs for technologies that have been highlighted by the pandemic. Actually, there are initiatives, certainly in the UK and I imagine globally, to address those needs, both in terms of availability of technology, but also in terms of ways of training people, sometimes at a distance, which can be challenging, to use that technology effectively for initially limited purposes. In my world, we talk about training wheels, which refers to those little wheels you used to get on bicycles when people were learning to ride with two wheels. That you start by doing things simply in a way that people can access and learn from, and then gradually you empower people to do more with technology. So I think that's about making more technologies available, often not particularly sophisticated, but essential, and empowering people to use that technology. And I think there's a lot more to be done in that area, but we've learned a lot already during this pandemic. You said there was another question.
Yes, thank you for that. So I'll go to the second question, which is, speaking of apps which collect personal data to track, trace, and curb the disease, when do you think is the time to set and establish an international legislative official basis for countries to commit not to jeopardize personal privacy?
I feel somewhat underqualified to comment on that, and I suspect Dr. Pate will be better qualified than me, but I think GDPR had a major influence across Europe, of course, so we have an example where we have worked across national boundaries by working together on standards of data privacy and individual privacy as well. I think that's a really good starting example to work from. Of course, to take it globally, that requires a level of international agreement that could hopefully build on what's been done in Europe, but extend it to the Far East, to America, to the global South, building on best practice. I mean, there are issues with GDPR which can sometimes you can end up with so many constraints on what it's possible to do with data that actually you can't work in people's best interests. So, I think there are rounds of review to be done even around GDPR, but I think it's a good model to start from for thinking about this as a global issue, but also recognizing that there are different value systems, across countries and cultures, which need to be addressed as part of that.
Thank you. Thank you very much for that. Dr. Pate, I'm tempted to ask you, but there are so many other questions that I would like to move us on to another equally interesting question, which is a reflection on how does the panel view links between COVID-19 and climate change? Are these separate issues or different aspects of the same issue?
I think if I can venture a response to that, I mean, they're separate but very closely related. They're very similar in the sense that they all require us to work together as a global community. They all require global leadership. They all require strong country actions, but also in collaboration with everyone else. It's not something that one country by itself will solve it. So from that point of view, and the science is also, as it unfolds, it should inform what we do rather than other, let's say, unscientific considerations. So this is a wake-up call. It's almost an existential threat to the world, as we've seen with COVID, which is still marching across the world, and climate change equally so. So I hope that this humbling moment for the global community will lead to reflection as to what we can do better in addressing challenges in our environment and climate change in particular, along with other infectious disease threats. They are also interconnected because global warming and resurgence of infectious diseases is also something that I think we've seen over time in terms of re-emergence of infectious diseases as well. So they are interconnected in that way, and how to deal with them requires a sort of a global perspective with strong country actions.
Thank you very much for that. Yeah, last year we had a fantastic lecture from Rachel Nugent, who reflected on some of these issues, the links between, for example, NCDs and the pandemic and/or climate crisis, and the fact that they are interrelated. So I'm pleased we are building on that. Andrew, I have one for you. So the questioner starts with, thank you very much, Professor Hayward, for your thoughtful words earlier and for speaking about the issues faced by marginalized groups in the UK. You mentioned the need for scientific and public health experts to have space to think about the questions that need asking. Is it possible to achieve this when the majority of the UK public health workforce are based within institutions that are closely linked to the government and therefore cannot easily speak truth to power? Any ideas about how this can be rectified?
I think that's a very good point, and I think a number of years ago, I can't remember the exact dates, many of us had concerns about the reorganisation of PHE to essentially move it into people being civil servants, if you like, rather than scientists. So moving it to, that was seen by many as a move that's made it harder for PHE to say what it wanted to say, because it was more part of government than separate to government. And I think this is probably a lesson internationally, I guess, that we do need a strong public health voice that has a degree of independence from political pressure. I'm not sure the best way to achieve that, because of course then again, if it is completely independent, then it may still not be listened to. But I think we do have a lot of soul searching to do about how the public health and scientific voice works with the political voice. And obviously in the end of the day, public health and scientists give advice, sometimes the right advice, sometimes the wrong advice, and politicians need to make those decisions. And I think everybody accepts that it's the politicians who need to make those decisions, but I think the structures that we have to allow, if you like, more dialogue between scientists and politicians is a bit lacking there. It's so formalised through the committee structures and the sort of time pressures of those committee structures. Perhaps made even worse in this situation by the fact that, you know, you're not having those conversations outside the committees because it's all online. So that sort of natural, you know, stuff that happens over coffee or, you know, in and out of the meetings, that's not happening. So I think we do have a lot to learn, and it's interesting to understand how some of the countries that have had a, you know, a more rapid and response, how they've structured their communications between scientists, public health people, and governments.
Thank you very much for that, Andrew. Perhaps I can go back to Dr. Pate. There is a question here about the importance of One Health in preparedness, particularly during a pandemic. One Health is still an area that needs a strong commitment from all stakeholders. Is the World Bank contributing to any specific effort towards the involvement of the One Health approach in global health preparedness?
Yes, I think the answer is yes. In the structure of the fast track facility that we've rolled out over the last 3 months, there's a key component of it, which is to try to intervene at the interface of human and animal health. That will require collaboration at the country level between sort of the agriculture, veterinary sectors, but also the health, human health sector as well. I think we need to think about how to incentivize those, but also to create those platforms that will enable collaboration between the animal health and also the human health, not only in terms of new pathogens, but like I've mentioned, also in terms of antimicrobial resistance. So that's really an important direction that I hope we can emerge out of this experience and be more intentional in terms of how we support that to move forward. So within the bank, our agriculture colleagues and in some of the countries where we've intervened, we've actually tried to foster that. And that's very positive. At the end of the day, countries have to make a determined decision to bring the two sectors together. I think medical schools and schools of veterinary medicine also need to be able to somehow cross-fertilize because, as we've said, zoonoses are increasingly the source of emerging infectious diseases, not only COVID, but also others that will be coming down the pike. So the collaboration has to take place at different levels. Ministries of health, ministries of agriculture, livestock, fishery, ministries of finance have to see them all as an interconnected piece at the country level to detect, but also when it comes to the response itself.
Thank you very much for that, Mohammed. I would like to follow on with another question for you. So this, I suspect, is from an economist because they want you to reflect on the following, that fiscal policies can either be contractionary or expansionary. Many governments are currently downsizing, which would create further vulnerability and poverty. What do you think?
I think my take is that there are certain, even within a contractionary policy environment, there is scope to protect the social sectors, so health, education, and to focus on the most vulnerable within society as those choices are made. We've seen how countries have responded in terms of the economic impact of COVID. Despite sort of declining revenues, we've seen how countries have sort of massively injected financing to deal with the economic impact. So even where resources are limited, the social sectors ought to be priority, especially now and beyond as we rebuild back post the pandemic, to ensure that that basis, including everyone, but also protecting health, education, and access to basic services, I think should be at the forefront in the choices that countries make.
Thank you for that, Mohammed. Andrew, I wonder if I can come back to you. There's a question about BAME. For those internationally outside the UK, this is an acronym for Black, Asian, and minority ethnic groups and the disproportionate risk that they suffer from the COVID epidemic here, and I suspect in the United States. So the question is, firstly, why are BAME more at risk of dying? And any thoughts on the UK's response to those inequalities in terms of the impact of COVID and the fact that there's a very slow comment release targeting research policies at this particular problem at the peak of the outbreak?
So I think the reasons behind the higher death rates in BAME groups are highly multifactorial, and they really range from, if you like, the sort of broader social determinants of disease. And so there's clear disparities that are related to poverty, which of course, unfortunately, there are higher levels of poverty and social disadvantage in BAME groups in the UK. And so some of the mechanisms by which that works through, I think, include higher levels of overcrowding within those communities. There's also a disproportionate tendency for people to be in frontline, key worker type occupations, so that people were not were more likely to still be being exposed to COVID. I think there was really no real attempt to make sure that the public health messaging reached all different communities and thought about language issues and cultural issues within that. I think there were further issues, for example, like intergenerational living, and so that would both mean that whilst people were going out and doing key worker jobs, working on the buses, within health services, etc., they may be being more likely to come back to intergenerational houses and infection transmitting to older people. And then I think there are some aspects of chronic disease, so for example levels of diabetes that differ in different ethnic groups and also provide a key vulnerability to it. I tend to think that most of this probably has a social rather than a biological explanation to it, and it highlights really endemic inequalities in our society that we need to start to think how to address, not just in BAME and non-BAME groups, but inequalities in general that are being exposed through this pandemic.
Thank you, Andrew. So we have another 11 minutes, and I will go through perhaps a few more questions and then use the last minutes to close off the event. And I would like to come back to you, Dr. Pate. You alluded to at the beginning of in your excellent lecture the variation in response by different countries. And one question posed here is, why did the world not learn from what happened in North Italy, and why did it not happen in the center of the world and the south, so the global center and the global south, in responding more effectively? I'd actually like to modify the question, because I don't think it's entirely true that all countries did listen. Why did some countries not listen?
It's a very important question. I think I'm not sure I have the precise answer for why, but I can speculate. It has a lot to do with leadership, where you've had strong political leadership that really brings in the scientific expertise, determined action by leaders at all levels. We've seen better efforts, even within countries. Take the Indian state of Kerala, for instance. It stands out compared to other states. Countries like New Zealand and others. There are many examples that you can show where strong leadership exercised, not necessarily only positions, but exercise of that leadership has led to more organized action, mobilizing of resources, and the trust between the citizens and the state and the responders strengthened such that people actually follow those instructions that are being given, or guidelines. Where that has been weak, where facts were not really respected and other factors came in, we've seen huge failures in national responses. And I think at the end of the day, if I can point to one thing, it's the exercise of leadership or lack of it. And where you've seen effective responses, people have exercised leadership. Leaders have stepped up, not only individuals, but collectively. And where you've seen major failures, I think if you go to the root of it, you might see individuals in positions that did not exercise the required leadership at that point.
Thank you very much, Mohammed. Ann, I wonder whether I can come to you, and this is a recurring question that has been asked by more than one person, which the WHO has described the phenomenon as infodemics. A lot of information is available through the media on research findings, which unfortunately creates a lot of confusion, sometimes purposely misconstrued, sometimes accidentally misconstrued, and a lot of material not peer-reviewed. What do we do about that?
There's a part of me that says that in the short term, that is unavoidable, because there is a lack of high quality information, and actually as a society, a global society, we need to kind of work out what are the facts and what are the misinterpretations. But I think there's also a question of learning to make sense of information better, by which I mean kind of upskilling the global population in terms of how we learn from evidence, how we question the quality of evidence, and hence interpret information that is presented to us in ways that are more or less cautious. And I think that's actually about education from a very young age, teaching our children to be more, and indeed our peers, to be perhaps more critical and to think about the sources of information, the evidence behind it, and hence the confidence that we can have in information. That is a very long-term agenda. That's not going to be fixed in the next year or three. You know, that's actually a really, really long-term agenda. Social media are causing all sorts of kind of bubbles of information which reinforce themselves within particular social groupings, by which I mean online social groupings, and dealing with misinformation, whether intentional or otherwise, within those kinds of cultures is a long-standing problem that I think we need to invest more research effort in, and also more public education to start to shift the balance of, what was that word? Infodemic? Yes. I'll have to use that one in a lecture one day.
Thank you for that, Anne. Andrew, can I give you two questions? I suspect they have very brief answers because they are straightforward epidemiological issues. So the first is any reflections on what we've learned about clinical trials and how to be more efficient to make sure that medicines get to people. And the second is a straightforward one of are children super spreaders?
Well, I mean, the clinical trials effort has, I think, been one of the key successes within this pandemic. The scale and speed with which those trials were instigated, and I think there was a critical point at which there could have been a decision either to just allow sort of compassionate use of different drugs without doing that in a trial-based infrastructure. And I think, well, around the world, and particularly in the UK, there was a really strong insistence that, well, actually, no, we really don't know enough to do that. And so this all has to be through trials. I think we've learned a lot that we can shortcut a lot of the, without decreasing the quality, a lot of the ethical and regulatory barriers to research. And I've certainly seen things that would normally have taken many, many, many months to get approved, getting approved within days, which is a good lesson for us in the future, I think. Your second question remind me, oh, children, and can they spread? Well, I think we'll probably find that out in September when they go back to school. But I think at the moment, it's very clear that children are much, much less likely to get severe disease. I think it's also likely that the clinical presentation in children is different, and they may be less likely to show classical signs of disease, the respiratory symptoms. I think we don't yet have good information on the extent to which children spread infection. I think that will emerge over the coming months. At the moment, if anything, there's a slight suggestion that they may spread less, but the studies to actually look at that are quite hard to design and execute. So I think we will find out more. I'm hoping we'll find out more from our own Virus Watch study, which is household transmission study, which will be able to measure that more directly.
Thank you very much for that, Andrew. So many more questions to ask. Unfortunately, we are running out of time, but I'm tempted to just one to eat further into the time I have to say thank you and ask Mohammed for one last time and perhaps give you the opportunity in case there are any further reflections you may want to add as well. And that question is a more philosophical one. That do you think that this pandemic happened because societies have become essentially greedier after money and business, and so are there fundamental ways societies need to change so that we achieve the goals of preventing such catastrophes?
Thank you. I think this pandemic is going to force us to rethink whether we've kept the right balance. I think we are off balance. If you look at the inequities that preceded this and how the pandemic has sort of really gotten into the cracks and affected everyone at the end of the day, for instance, that's reflective of that lack of balance. So I hope as we emerge, we will think about our position in the global ecosystem and to have a more balanced approach, whether it's with infectious disease pathogens or whether it's even issues of climate change and the environment. So that's, I hope that's what we will learn from it. It's been a very tough period, but at the same time, it's also been an inspiring period when you see the frontline health workers in many countries struggling to deliver services despite very difficult circumstances. It's also a humbling moment. And I think Richard at the very outset of the lecture alluded to it's almost a paradigm changing event. I hope when we come out of this, we will reflect and build something different, not to rebuild the past, because the past was clearly inadequate. It didn't protect us, and I think we have seen major gaps across different dimensions. So I hope we'll emerge out of this to think about a new paradigm in the global health community, anchored around tangible changes, actions at the country level, leadership by countries at the global level, and holding leaders accountable and holding each other accountable as well. So thank you very much, Ibrahim and UCL, as well as the Lancet, for really giving this opportunity for us to share a perspective with you. Thank you.
Thank you very much indeed. So that brings us to the last bit of the meeting, and it remains now for me to thank our speakers. But before I do so, permit me to take a couple of minutes to share a few thoughts. So first, I think you would agree with me, having listened to our speakers, that indeed these are unusual times, not only because of the obvious that we are having to meet, not face to face, but on this forum electronically, but also because of disruption in our lives all this while. And while many aspects of this virus have been very clear from the beginning, the contrast in responses between the various countries, as alluded to by many of our panelists, has been very stark. Unfortunately, many low and middle income countries have borne the consequences of the virus and the necessary measures that have been taken to mitigate its effect. From the beginning of this pandemic, I've had two key roles that I have learned a lot from in the pandemic. The first relates to my role as scientific advisor to the House of Lords Science of COVID review, where I've listened to the amazing science done by colleagues from multiple universities in the UK, as well as some of the staggering policy failures that we are learning from. I've also served as a scientific advisor to the Nigerian Presidential Task Force on COVID-19, where with much less resources, colleagues have been courageous to take decisions, listen to evidence, and respond promptly. And I have no doubt that these actions have saved lives. Obviously, the epidemic continues to evolve, and that the younger population of Nigeria perhaps have something to do with it, but definitely lives have been saved by the courage of colleagues in leadership positions in low and middle income countries. Through these roles, I've learned that making a public statement on the state of the pandemic is fraught with risk due to the rapid change in knowledge, and we will find out that many of the things we said so conclusively today are probably wrong, but we are learning. Second, our prestigious annual UCL-Lancet Lecture is an opportunity to call on the UCL community and our global collaborators and friends to act on an important area on global health, and today's priority happens to be COVID. So if you've been inspired by the challenges articulated in the lecture by Dr. Pate or any of our panelists, especially as they relate to the poorest countries, this is your opportunity to act. This is your opportunity to contribute by holding our politicians to account, both here in the UK and internationally. If I might quote Richard Horton from his newly published book, The COVID Catastrophe, one lesson of the COVID-19 is that every country must now begin a national conversation about how far it is willing to go and how much the public is willing to pay for a health system that can save lives when a pandemic arrives again, as it surely will. We need our governments to do the right thing here, as well as in lower middle income countries. So when I asked Dr. Pate to speak on this rapidly changing topic, which fundamentally affects all our lives, I was very delighted that he accepted, not just because I knew he would deliver an outstanding lecture, but because I was confident that to do justice to this complex and rapidly evolving topic, with a focus on the poorest in the world, the World Bank's Global Health Director has a vantage position to inform global health developments. Mohammed, I'm very grateful that you accepted to do this. Colleagues, I hope you will agree with me that it has been a thoroughly enjoyable and informative afternoon. We are grateful to you for taking the time out of your busy schedule to give this lecture. Thank you again, Mohammed. To my colleagues, Andrew Hayward and Ann Blandford, thank you for skillfully demonstrating what is best about our multi-faculty university, drawing on the best intellect in sciences and the arts to respond to any human challenge. Your work exemplifies the range of input from within UCL on the UK as well as internationally. We make a difference because we care and because we have the right intellect to bring together expertise. There are many in addition to you that are contributing, and I'd like to use this opportunity to thank all our colleagues in UCL, for example, my partners in the Pandora Consortium, who are contributing to the response in many countries. Thank you, Andrew, thank you, Anne, for supporting the UK response and for giving the response to this lecture. I believe UCL and the Lancet have a lot in common, allowing us to agree speakers each year with ease. The UCL-Lancet Lecture has a history of great speakers, from leaders of thought in society to former prime ministers and ministers of health in multiple countries. After about 2 decades of doing this, it's become a landmark event in our calendar. I'm superbly grateful to Richard Horton, the editor of the Lancet, for continuing to support this year's event. And I'm really sorry, Richard, that you couldn't chair this event because of our technological failures. Very, very insightful contribution as always in introducing and in the questions that you posed to the panel. To our wonderful audience, thank you for your contributions and questions. An event such as this is only ever as good as the wonderful questions that you post. For any event to work smoothly, it requires extensive planning. And this year, not different from any other, it's my pleasure to thank the UCL events team, the UCL Grand Challenges team, in particular Nina, and my team at the UCL Institute for Global Health for putting this together. Finally, I do not normally thank my boss, the provost, but this is a special year because this is the last time that Professor Michael Arthur will be hosting the lecture. Michael, we'll miss you. You've been a strong ally of global health in our global university. You've championed and supported issues that affect disadvantaged groups from our ivory tower while supporting equality across a range of dimensions, from sexuality to race, from disability to gender. We wish you the very best for the future. And I'd like to add this to the few words you added, which is great lecture and discussion. Thank you to Dr. Pate and panelists for an inspirational and thoroughly enjoyable discussion that has been very much in the spirit of the annual Lancet Lecture. Thank you to Richard Horton and the Lancet. You've been a great friend and a partner of UCL. And I'll close by repeating the words of Richard Horton. We look forward to next year, and we hope we can meet face to face. Stay safe and well, everyone. Thank you.
Thank you.
Thank you.